Anna-Marie Saarinen.
Thank you. Thank you so much for having me. Those are tough acts to follow. I'll do my best possible job. Thank you so much to the organizers, the Joint Commission, and to the Massimo and Patient Safety Foundations. And thanks for having it here so I could leave the minus 40 in Minnesota back home. That's really awesome. I am a co-founder and chairman of my organization, which basically is trying to leverage technologies, health information technologies, and medical technologies to improve outcomes and reduce disparities for newborns specifically. And I'm speaking on behalf today of our executive director, Jim Bialik, who is here, was here, also just has a newborn himself, and congratulations. And a wonderful advisory and technical board around the country and around the world who helps us kind of determine on a daily basis what we can do better in trying to help these youngest patients. So our commitment, let's see, am I supposed to be doing this myself, right? Advancing the slides. Oh yeah, we already did that. Okay, awesome. So our commitment focuses on the problem you heard a lot about in the last panel, and that is that babies are born every single day with really awful conditions that can't be seen by the naked eye. These are asymptomatic kids who run the risk of leaving a nursery either misdiagnosed or undiagnosed. So we sort of looked at that problem both in the United States and internationally. And in the US, again, you heard some of these statistics, how many newborns can run the risk of leaving with undiagnosed congenital heart disease. It's the most prevalent and deadly of all birth defects, and we simply had no screening for it up until these last few years. And of the 40,000 infants who are diagnosed each year with CHD, 4,000 of them will not reach their first birthday. So if we can take this sort of measurable chunk out of these deaths right here in the United States, that is sort of the aim of our US side of our commitment. Internationally, 4 million babies, newborns, are dying each year. Over 1 million of them are specifically dying from neonatal infection, sepsis, or pneumonia. And it is one of the single greatest unmet goals of the Millennium Development Goals. So many of these goals have seen such measurable progress, but this particular one, neonatal mortality, has been a very tough nut to crack. And so being able to look at why that's happening and what we can do better was part of our international commitment. So our plan, the elements of our plan, include providing tools to the hospitals. So heart screening requires all sorts of interesting things that a number of providers haven't thought through or had to deal with in any sort of massive scale. So how do we get kids from point A to point B? What are the referral channels? How do you get a follow-up diagnostic for a failed pulse ox screen? These are sort of the nitty-gritty, again, what Lisa was talking about, where the rubber meets the road. So we've been working really hard since 2009 to try to come up with some of these tools and continue to as part of our plan moving forward to improve patient safety. The Newborn Health Connect Hospital Certification Project is something that I hope the Joint Commission will help us take a look at and improve, actually. It's very much modeled after much of the work that they do, much of the wonderful work that they do. And it's not only providing this sort of, we call it the diaper manifesto for hospitals, so helping them not only have best practices and standards in place for their newborn nurseries, but really looking at how their connectivity and their health and IT infrastructure can better support care, particularly for hospitals that don't have a NICU. What sort of immediate access would they have with an outside hospital that would have specialists to help that baby that might be in trouble? And then on the policy side, continue to work with policymakers at the state and federal level so that every hospital of every size, no matter where they are, can implement these protocols in a sane way that actually improves workflow and improves outcomes for kids. So internationally, this has been just a fascinating thing to work on over the past year in developing our commitment. And as we saw the data coming in from full implementations at the state level of CCHD screening, we found out that that algorithm that Dr. Granelli talked about was actually incredibly effective at detecting these other serious conditions in babies. Here in the United States even, we miss sepsis and other respiratory illness and pneumonia in kids. So if you're talking about half of the fails of pulse oximetry screening being something other than CCHD, those are not false positives. They are actual true positives, just for a different condition. So in the developing world, having access to cardiac care, meaning surgery in the infant period, is very difficult. But having access to supplemental oxygen or antibiotics or things that can save a life of a child that has these secondary conditions is much easier and very viable. So that has been our focus, was flipping that algorithm on its side, making those secondary targets the primary targets internationally, and we're also still going to be able to detect the birth defects, which are still CHD being the number 1 or number 2 birth defect on most lists in most countries. So our goal, if we can reduce these infection-related and pneumonia-related newborn deaths by 35%, I mean, we would be talking about hundreds of thousands of children just in the first few years. And then as a population health screening, if you're looking at this, say a country says, we would like to screen for hypoxemia in our newborns, it'd be helping them develop, as we are now, low-cost, clinically accurate tools and implementations on pilot programs. And until very recently, where we've been able to have a mobile-enabled technology that's clinically appropriate for use in newborns, the scalability of that was incredibly difficult. So we're finally there, and that's why, honestly, I've worked on a lot of cool things in the last few years. This is the coolest. I mean, really has the opportunity to impact millions of children. Okay, results were achieved. We talked a little bit about this in the panel, so I don't need to get into too much of it other than to say, in the last year alone, with only 9 states fully implemented, we know of 220 lives saved. These were babies that would have been discharged with critical heart lesions had it not been for the pulse oximetry screen. That's a really profoundly wonderful number. We did complete and distribute an open source downloadable training video, nurse training video for hospitals. It's really great. It's like 9 minutes. Nurses explaining how to do it. It was done in conjunction with the University of Minnesota, Amplatz Children's Hospital, and the Minnesota Department of Health. If anybody is on the hospital side and wants that, you can either go to our website or I can tell you how to get it. But the nurses have said it's really helpful because it has a little bit of the advocacy and parent piece to it that explains why we do it, but also the very technical nature. How do you put the wrap on? What sort of condition should the baby be in? All the details you need to know. Children's National, by the way, has a wonderful set of videos that work on this as well. And then the other thing that we have achieved in the US is kind of really focusing on this data piece. So the role of public health is critically important, and those of you who work on the provider side, I think, understand this, but making it easy for these hospitals, not an extra thing for the nurses to do, but to report their pulse oximetry and all newborn screening results to their state departments of health. And the reason that's important was outlined by Mitch earlier, and that's because if we don't know the numbers, we can't do quality improvement. So if we don't know that the hospital in Duluth is having a false positive rate 3 times what all of the surrounding hospitals are, then how can we possibly reach out to them and say, what is it? Is it your technology? Is it your screening protocol? So the data is just so critically important, and I feel like that part of our commitment, we've really gone far in advancing. And thanks to our executive director, Jim Bialik, who, by the way, goes in front of Congress all the time and drives that home with a hard nail. And then internationally, this year we had just the profound pleasure of hosting the first International Summit on Newborn Screening and Congenital Heart Disease in China. We did some field research days with an incredible team of international delegates that came with us, including Ann Granelli, Dr. Sola, if he's here. Just being able to see what it's like in both rural and urban China, how committed they are actually to this particular disease, and of course the secondary targets as well. But being able to get the public health leadership in a country that has 18 million births, moving towards adding this as a required screening in that country has been one of the most exciting things I've ever been a part of, and we continue to work with them. I was just in Shanghai about a month ago working on that. We presented at just countless conferences on this particular topic, continue to provide briefings wherever they're needed. There are 17 states that still have not required this screening by whatever mechanism. Anybody here from Wisconsin? I have Governor Walker's cell phone number. I mean, I'm sorry, but there was a baby 3 weeks ago. Just, and they're screening at 80% of their hospitals, but it's the 20%. And that baby almost died with hypoplastic left heart syndrome, was diagnosed 2 weeks late. That just can't happen anymore. And then the Born Project launch, which was birth oximetry routine for newborns, which was really taking this finally low-cost mobile-enabled pulse oximetry technology and bringing this to mature developing countries to help diagnose hypoxemia. And then I also had I don't even know how the world works, like this is serendipity, but going to the International Conference on Birth Defects to actually speak on this topic. It happened to be in Cebu, in the Philippines. I landed the day after the typhoon. And there were 35 countries represented there. And I had 10 countries come up to me over the period of time that I was there and agreed to sign the Born Accord, which is essentially a public health imperative that says that newborn screening for hypoxemia is absolutely critical to reducing neonatal mortality in their countries. And it was incredibly gratifying, and so we are moving forward with those countries, but just being on the ground there was a life-altering experience, as of many that I've had recently. So here's just a few. I just wanted to share a few of the photos from November in the Philippines. This is the actual nursery where the mothers are sent. Some of these women in that photo on the left delivered their babies an hour ago. They were 4 to a bed. So it'd be like a mother, a baby, mother, baby, mother, baby. And this is the main provincial hospital in Cebu, where a lot of the triage was happening from Leyte and within about that 100-mile radius of where the typhoon did its most damage. I spent almost every spare minute I could when I was not at the conference in the NICU at this hospital. And it's not a very good picture of that nursery. They have about 60 babies in that NICU, and they're all in bassinets like that one. So they have no pulse oximetry technology, no incubators. 50% of the babies in that NICU were premature. They didn't have light therapy. They didn't have their eyes covered. They were just in open mess. They did have a few oxygen containers. But a midnight phone call to Sam Larson, wherever he is, from Draeger, and Paul Jansen from Massimo, yielded pulse oximetry equipment for this hospital, and I'm told 6 incubators have been sent to them since November. So they have the equipment now that they need. And then just another thing about this baby on the bottom. They asked me to do grand rounds with their neonatologists at this hospital to show them how pulse oximetry worked on a newborn with a wrap and a probe. So that baby I saw my second night in, and frankly, he looked like what my daughter looked like on her 3rd day of life. It's retracting his chest, and he's trying to breathe, and his color was just off. And I said, what have you checked this baby, with anything? And they said, well, we're not sure. He might be sick. He might have infection. But we're not sure. So that number, top number on the iPod is a 35. That's a bad number if you're if you know what pulse ox value should be for a baby. It should be above 95%. Even if you're really, really newborn, at least above 90. That number never got above 50 on that baby. Unfortunately, he died 3 days later, diagnosed the day after with tetralogy of Fallot, very serious heart lesion. And all these babies would need to be airlifted to Manila. That's the only place that does pediatric heart surgery in the Philippines. And it's just yet another sort of tragic illustration of how being able to do things just a little bit sooner with just a little bit of extra support might save a life and change the world of a family, of that family. And I'll just tell you, there isn't a day that goes by that I don't realize that if my own daughter had been born in any of 97% of the rest of this world, I would just be another grieving mother. So that was my daughter on the day she was born. 12/12/08, happy family. She was beautiful, 9 APGARs. We went from that happy picture to finding out at 2 days old that her heart was 3 times the size it should have been at the point of discharge, and she was in profound heart failure, asymptomatic, to the photo you see at 3 months of age, where she had open heart surgery. So, she's the reason we all do what we do at the Newborn Foundation, frankly, and we don't limit ourselves to congenital heart disease, but this was a catalyst for not just making sure we're screening for the most prevalent birth defect and getting that condition nominated and running it through the policy mill, but looking at everything that parents do, that hospitals do, that caregivers do, clinicians, and saying, what are the pieces of the puzzle that the public and the private partnerships can address? And I will just say, in Eve's 60 months on this planet, she's been under anesthesia 17 times, 9 times in the past year alone. She's had 24 echocardiograms, 50 chest x-rays, 6 transfusions, 8 MRIs, 2 heart surgeries, and 2 weeks after this meeting last year was diagnosed with a brain tumor. Had a brain surgery this year. Tumor grew back this summer. But we're waiting and watching and seeing the spark in a girl that truly, I want to believe has made a real difference in this world. So it's my really, really great pleasure to introduce to you the cutest kid I know and the bravest kid I know, Eve Sarnan.